Hi everyone. Welcome. My name is Barb Cochran, as usual, and I'm from the Deterny Center for Healthy Aging here in the School of Nursing and representing the Northwest Geriatric Education Center, which is sponsoring this lecture series. Before I introduce our speaker, I wanted to mention that the lectures from the winter series are now available online on our Northwest GEC website. They're free. You just have to register on the website. If you're already registered, you should be able to access them. The website address is nwgec.org, and they will be up there until they get updated in years to come. So enjoy. We have about 60 lectures posted online for people. And today I'm pleased to introduce Whitney Carlson. She is an assistant professor in the Department of Psychiatry. She's had a long-standing interest in mood disorders, depression in particular. She's board certified in geriatric psychiatry. Since medical school, she's had an interest in caring for those with chronic psychotic disorders, from the sometimes complex pharmacology involved to the day-to-day challenges of living with a chronic mental illness. As a geriatric psychiatrist, she has had an interest not only in the aging patient with chronic psychotic disorders, but also psychosis that presents in late life, including in the context of acute medical illness. In her role at Harborview Medical Center, she cares for many patients with lifelong schizophrenia who are aging, as well as newly identified patients with late onset psychosis that meet criteria for schizophrenia. So very, very interesting topic today, and welcome, Whitney.
Thanks a lot, Barbara. It's nice to be back. I was here about 2 years ago, and a little bit different twist slightly than the last time I was here. I love psychotic disorders, and I know that's odd for people who are in psychiatry, but this is something I am passionate about, and I hope that you'll learn a little bit about how to take care of these people too. Okay, the goals and objectives are in your handout. And basically, because it's my understanding it's kind of a mixed audience, I wanted to run through the definition of psychotic symptoms, mainly because the things that sometimes people describe as psychotic are not. They have behaviors that aren't really psychosis, and so I think it's important to know what the language that we're using to talk about the differential diagnosis of psychosis, particularly in older adults. When and if to treat psychotic symptoms with antipsychotic medications, because you don't always have to do that, and particularly with the risks that are associated with those for dementia, it's important to know what you're treating and if you should. And then discussing additional resources for dementia and mental health services. So I want you to think about this mainly in the sense of empathizing with people who might have psychotic symptoms. I was doing a training for hospice in Franciscan Hospice in Tacoma, and one of our case managers, who is very wise, suggested that we've all been delusional at some point in our life if we have ever believed in the Tooth Fairy or Santa Claus. Children often have imaginary friends, so in some sense you could look at psychotic symptoms that way. We've all had some false belief that wasn't actually based in reality until we learned better. The difference for people who have a mental illness or delusions that are fixed is that they can't go beyond that. So once they get evidence, it still doesn't change their mind. So it's immutable. It doesn't go away even though you have refuting evidence for that. So it's fixed. It doesn't go away. Hallucinations are sensory misperceptions. They occur in the absence of corresponding sensory stimuli. So what I mean by that is there's nothing there. So there's nothing that's causing a voice. There's not a radio in the room. There's not a TV on. There's not a person in the room. And that's different than illusions, where there's an actual stimulus. Sorry about the typo there. For example, I had a person who thought there was a doorstop that was gray on the wall in a hospital room, and they thought that was a mouse. Well, there's something actually there. They just misperceive it as something it's not. So there is actually a stimulus there, and that's a little different. And so it's important to know if there's actually something there, because sometimes there actually is something there. So it's important to investigate that too. I work in nursing homes, and we had a couple that was a brother and sister that lived in the same room, and one had schizophrenia and the other one had dementia. and they were talking about spiders, so naturally they call psychiatry because they're seeing spiders. And I was on my way in to see them and thinking that was unusual that they would both be having hallucination of the same thing at the same time. And the nurse said, no, there actually was a spider in the room. So you got to be careful with that. And sometimes there was something there and it's not there. And so it's hard, but do your best to investigate it because sometimes it's actually true. So that's important. You don't want to be throwing a high-risk medication at something that actually exists. Auditory and visual hallucinations are the most common type of hallucinations in mental illness in general, in dementia, in organic conditions. Visual hallucinations often are organic, meaning they're based on some kind of brain problem or some kind of medical issue or medication. People with schizophrenia can still have that, bipolar disorder, depression with psychotic features, but they're a lot more unusual. So particularly an older adult with no history of mental illness before suddenly has visual hallucinations, I automatically think that there's something medical going on because it's by far and away the most common reason for that. Okay, and the differential is important because if we're going to use medications for psychotic symptoms, there are risks and benefits of those. There's a high morbidity that goes with those, meaning side effects and death sometimes for some people. So you really want to know what you're treating, how long you want to treat it, and what's the potential underlying cause of it. And sometimes the different diagnoses lead to different treatments. So if a psychotic symptom is being caused by a medication, the best thing to do is to stop the medication and then the psychosis will go away, rather than throw something at it that's just going to basically fight the medication. And that's a really common example of that is in Parkinson's disease, because those medications, often because they're dopamine agents, cause psychotic symptoms. Dopamine is what we actually dampen down in schizophrenia with medications. So you can see if you had too much dopamine, you might have hallucinations. So if you can lower the dose or stop it, that's the best thing to do. Types of support needed are sometimes different depending on what's going on, and we'll get into that a little bit. And then the course of treatment, if it's a chronic mental illness that's worsening, or if it's a late onset schizophrenia, for example, they may need longer term treatment with medications than, say, dementia does. So you might want to use dementia medication a lot more short term because of the risks with that. And then psychotic symptoms are often used to describe non-psychotic behavioral syndromes, and I know you've had some lectures from people on behaviors in dementia, for example. So it's really important to know what you're describing and seeing. So with all medical issues, really, and behaviors and situations, you're always a detective. So you always want to know who has the problem, what's going on, why does it seem to be happening, where and when. And so that's sort of how I want you to think about these kind of problems. So who? So I work mostly with geriatric patients in clinic and in nursing home hospital. Certain kinds of problems occur in certain groups of people. So I mentioned the issue around visual hallucinations being unusual in older adults if they've never had anything before. So if I hear older adult visual hallucination, that makes me think of a certain group of diagnoses versus something else. So you want to know who's coming to see you, or who are you about to go into a hospital room to see, or a clinic. What's their social situation? Are they living alone? Are they living in a assisted living? Are they with family? And that's important because you want to know if they are having behaviors, who that's impacting, and if people are safe. And so some psychotic disorders can lead to really bad behaviors, and so you want to make sure that you know who's involved. And who's concerned about this? Sometimes it's not the patient. In fact, often it's not the patient. They usually come in and, oh no, everything's fine. Well, you'd be distressed too if this was happening to you. It's often the family or the adult family home or the hospital that's concerned. But sometimes it's both. And then if you can get it, is there any prior history of this? Is this a person that's had a history of intermittent mental illness symptoms all their life? Is it new? And what did that look like? Okay, and then the what. What is the behavior? What are the signs, which is what people see, and the symptoms, which is what the person experienced? Is it really psychosis? Is it delusions? Is it hallucinations? Is it, they can't put a story together because they're disorganized? Are they not doing things that makes you think that, they have dementia? What is it that's the concern? And usually the psychosis is what's driving the visit, in my case. But what has been happening before that? That may be the acute issue, but are there other things that have been happening along the way that might give you a clue to the diagnosis? So has there been a concern about memory for a while? Has there been word finding problems? Has there been a sudden change in behavior, like they're isolating at home, they're duct taping their door closed? Are they out in the lawn yelling at people? What other things might be clues to the behavior and the syndrome? And then has there been anything done so far to evaluate that problem? And has it been treated and has it helped? So you want to know you're not trying to reinvent the wheel. If something's already been tried, you don't want to go down that pathway again. Why are they presenting now? That's a common one. And usually it's some kind of crisis-driven issue in psychiatry. They're about to get kicked out of their housing, their spouse can't take it anymore, their kids are leaving work constantly, so they're burnt out, or they're calling the police and the police are getting involved. Why are they presenting now? What's the purpose? In the hospital, it's sometimes for nursing, I can't do anything with them, they're not taking their medicines, we can't do any blood draws, they're paranoid, whatever. So why is it presenting now? What's the acute issue? And then when did it start? Is it acute? Is it something that's chronic that's now getting worse? Like they've had episodes of this and it's now a decompensation, for example. And then is there anything that gives you a clue about the timing related to other things? Like they have a recent medical issue. Well, they just had a cabbage and they got, meaning a cardiac bypass surgery. They got out of the hospital. They're on all these pain medications. They're not acting themselves. Is there something like that? Did someone die? Did they have a move? Is there somebody new living with them? In a nursing home, do they have a new roommate? All these things can go into why they act the way they do or what they're experiencing. Medication changes is a big one too. And then I mentioned where do they live and with whom. Sometimes they're living alone, and that can also be a concern in terms of their own safety or their own ability to care for themselves. Is their placement at risk? Are they threatening somebody or making people feel afraid? Do the symptoms only occur at home, or they go out in the community and they're normal? They go home and things are not good again. So it can give you clues as to what's going on. So I'm going to start with a little bit of a case. I'm going to go through a few of the differentials, and then we'll come back to the case. So I was looking through the slides and realizing that the case description goes a little bit beyond the differential. But we will come back to some of the symptoms this person has. But this is just sort of the initial information that you might have on a person. So this is an 83-year-old woman. She's living independently, and she presents for evaluation of psychosis, but you don't know what that means yet. So these are some of the things that I would like to see. This is my ideal. This almost never happens, but if you can get it, it's good. It doesn't mean if you're a medical person, a social worker, a nurse, these are things that you could try to gather for someone who might be coming to see your patient. Any prior workup, if you can get records ahead of time, if this has been something that's been happening for a while, primary care doctor notes, nursing notes from where they live, caregiver notes, a phone call with the family if they can give you information before you see the patient if you can. Have the patient and the family bring in their medications, and we all know in the hospital that's really rare, and even in clinic where you think they would know they were going to need that, not so much. And the full list is the key, because often they take a lot of other medicines that are not on their official list that they take to the doctor, like Benadryl, Tylenol, their husband's pain medication, heroin, medications, anything can go. And so it's really important that you ask about all of them. And herbals, I saw a sign outside the nursing door about herbal medications, which is another big factor. And then be aware of all players in their medical care, meaning doctors often don't talk to each other very well, as most of you who have been in medical care know. And so there are often multiple people prescribing medications who don't know what the other people are doing. And I will not go into that today, but that's a big problem in medical care. But you need to know who's caring for the person, because they may be, at odds with each other without knowing it. So as you're evaluating someone, these are some of the other things. Not only the medication list, but are they actually taking the medication? And the reason I point these out is because often people think people are taking their medicines properly, and they often aren't, particularly older people, for a lot of reasons. They may never fill them. They may be too expensive. They may have to choose between taking a medicine and eating. They might forget and then double up the next day. Somebody might find all their pills on the floor. They throw them away, any number of things. Their other demented spouse takes them. There's many things that can happen. So your differential is broad. Lab results, head imaging, that's more for the doctor people, but that can be helpful in helping us sort out what's been done already and what might be a player. Collateral, and that can include, if you know, in my healthcare system, I'm fortunate to have a medical record electronically, and so often people have, I can tell what's been going on. They've been visiting the ER, they're falling, there are all kinds of stuff I can see, their social work notes. Try to get as much information as you can along the way. If you get hospital records, this is more for medical providers, actually read the nursing notes. They actually do write some really, really good stuff. And I emphasize that because a lot of people don't read them. And I realize I have more time than the average person sometimes, but there's a lot of clues in there in terms of behaviors often, and that can help you put the story together. And then ask about substance use and over-the-counter medicines. People use a lot more drugs and alcohol than you think they do in older adults. And that's going to become a different problem as the cohort ages, because we will have the children of the 60s and legalize marijuana and all kinds of stuff, in Seattle anyway, to think about. Okay, so this is the broadest differential of psychosis in older adults. It's not exhaustive, but these are the things that typically come up. Delirium, by far and away, the most common cause of psychotic symptoms, I would say. Secondary to general medical condition, and I mean things that have as a part of their potential symptoms psychosis. So Parkinson's disease with or without medication can have psychotic symptoms. Lewy body dementia, which I think you heard Dr. Thilke talk about, has visual hallucinations as a possibility. That's secondary to the general medical condition. There's no other explanation than the brain problem. Substance-induced, not delirium, that can be intoxication, withdrawal of illicit substances or legal substances. It can be prescribed medications. And what I mean by not delirium is sometimes they have psychotic symptoms, but they're not having the course of delirium, which I think you're going to have a lecture on. I don't think you've had that yet, but you'll learn a little bit more about that and why it's a little different. Dementia, there's certain kinds of dementia that tend to have different kinds of psychotic symptoms, some more than others, and so we'll talk about that. Mood disorders with psychotic features can be bipolar disorder, can be major depression with psychotic features. So those can have that element. And you'll get the clue that they have other symptoms besides just psychosis. They'll have depression, or they'll have erratic behavior that's, they're not sleeping, they're manic. So you'll get some clues from that. Delusional disorder is a disorder that can happen in two stages of life, earlier, like around the 40s, 30s, 40s, and later in life. I just saw somebody this morning with that problem. It's a difficult one, so we'll talk a little bit about that. And then schizophrenia, either chronic, aging, or late onset, and there really is such a thing as late onset schizophrenia. All right, so delirium I'm actually not going to go into because you're going to have a big lecture on that. But basically what I want you to remember is that it's usually an acute situation, like just started happening 3 days ago, just got out of the hospital, complaining of X symptom, just started X medication, and it might take a little asking to get at that, but they're not themselves, or they usually are oriented, but now they're not, and it comes and goes. And a classic situation, say in the hospital, is the doctor will say, well, how can they be delirious? Because this morning I saw them and they were totally oriented. I go see them and they're oriented, not at all. It comes and goes, so it's a fluctuation. So that's the key, versus dementia, which tends to be very statically disoriented if they're going to have that kind of dementia. The other piece is that delirium is often superimposed on underlying cognitive problem, and they're more susceptible to it. So people who have abnormal brains tend to get delirium more often. So sometimes that can be a sign that something else is going to become, they're starting to have a dementia if they have a health problem and they get delirious. So you want to try to treat and manage the etiology, because otherwise it won't get better. And they might take a little bit longer to get better from delirium too. And if you have somebody that's delirious, don't say they're demented until you know the delirium's gone, because sometimes it gets better, remarkably better, and then they're normal cognition. So this is ongoing with the case. So the patient's calling her family, reporting someone breaking into her home and stealing things. I cannot tell you how often this symptom comes up, and this was problem this morning. They're coming in, I know it because they're rearranging my stuff, and the paper was folded and it wasn't this morning, and there's crumbs in my purse and I didn't put them there. All kinds of evidence. This case, this is an 83-year-old woman. She has, unlike most patients, a very short medication list and a very short medical problem list. And I kept it simple for a reason, but often it's a lot more complicated than that. She's already had imaging of her head, so there's nothing like a huge brain tumor or some major stroke or anything like that going on. Nothing awful. So that's been ruled out. Her husband died 6 months ago, and she just moved, so a couple of potential stressors. Her electricity, her kids say, is in danger of being shut off because she hasn't paid her bill, and she's getting overdraft notices from the bank. So what does that mean? That could mean lots of things. It could mean she's just not organized because of her psychotic symptoms. It could mean she's having activities of daily living issues in terms of bill payment and tracking things cognitively, or just overwhelmed. Okay, so I mentioned asking other history. Have she had any other cognitive symptoms? How has her mood and general outlook been? Because she's had a couple of changes. Has she been depressed? Because you're trying to rule that out. How's her home look? Is she taking care of herself? Is she taking care of her house? Is it totally, dirty, and she's usually a meticulous housekeeper? Is she not showering, doesn't care, or dressing funny suddenly, or carrying all her belongings with her, something like that? She refilling her medications and taking them properly? Actually call the pharmacy. Sometimes families are like, oh yeah, she's taking them every day. She hasn't filled them for like 3 months, And for some conditions, that's important. And past history, just so you know what else she might have had. And then what does she present as evidence people are breaking in? And that's to get at the kind of symptoms she might have. So does she see people doing that? Does she find things missing? Is it that, there's a scratch on the table and there wasn't one before? What is she seeing or he seeing that gives them the proof, so to speak? So along those lines, this particular case, the mood's been okay after her husband's death. She did the appropriate, bereavement. He was sick for a long time. He died. She was sad for a while, but nothing really horrendously complicated with bereavement. She's still sad once in a while, but nothing major that way. And she wasn't really having any mood problems until she started talking about these theft issues. And then she said, well, why is this happening? Why are people picking on me? So she's dysphoric about that. She's been having some short-term memory problems, her family says, and trouble finding words. And to me, that usually means some kind of dementia coming, and that's not always the case. She's also been less active socially for a few years, which predated the death of her husband, so it's not necessarily she's not partnered up. There's something else that's contributing to that. She's been calling the police, so your red flags are going up, because that means she's really distressed. Something's going on. Most people do not call the police unless they're really scared or something's really upsetting them. Some people do, but not the average person. She's not sleeping well. She's worried about her safety, which is probably why she's calling the police. And her family says that these stolen items sometimes turn up later. She will find them and say, well, they must have found out I was upset and put them back. Or the family will say, well, here's your dress hanging in the closet. Well, I would never put it there. It's the evidence is just, but they forgot. They probably didn't remember they hung it up. Or a well-meaning child hung it up for them and they didn't realize that. Types of dementia, I won't go into total detail. I'll try to cover a few symptoms that are important. These are the major types. There's many, many kinds of dementia, but these are sort of the top ones to think about. These are the Psychiatry Bible definition of dementia, which is unfortunately all about to change this summer with DSM-5. But at least at the current moment, this is what's in our definition of diagnosing dementia. And one of the major things that'll probably change is that it won't require memory impairment necessarily, because some dementias don't present with memory impairment as their primary problem. Alzheimer's disease does, but a lot of other dementias do not. And then they have to have another additional deficit. So in terms of Alzheimer's disease, psychosis is super common. 50% of people with Alzheimer's will have some kind of psychotic symptom at some point, which is a lot. So it's important to understand that. It usually comes in the middle stages of the disease, and usually the mini-mental or full-steam mini-mental is in the mid-teens. Sometimes it's a little higher than that. But if somebody's coming in for psychosis, they have a history of memory problems, I almost always can guess what their mini-mental is already going to be. unless they're really, really educated, in which case they can cover well sometimes. Delusions are the most common. They're usually simple, non-bizarre, and paranoid. So it's the kind of thing where you say, well, it could happen, maybe that's happening to them. It's not like, Johnny over there is sending me telepathic statements from above and, wearing foil on their head. There's not going to be that kind of disorganized behavior, that kind of theme. It's usually something that's potentially possible. Some of them are a little odd. So theft is really common. Somebody's stealing my stuff. The caregiver's an imposter. You look like my husband, but you're actually not my husband. And that's called Capgras syndrome. And that's not specifically Alzheimer's disease. That can go with other neurologic illnesses too. But that becomes obviously a big stressor for the caregiver, because often if it's a spouse, they're really hurt by that. Of course I'm your husband. What are you talking about? But then they don't trust them, and you're not helping me because you're really an imposter. Abandonment or infidelity, you're cheating on me, why would you help me, because you're having an affair, which may or may not be true, may be true. Home is not the home, and that can, if they've just moved, I would say not to read too much into that as a delusion, because they may not recognize it as home yet. So that's a common thing when people move to a nursing home or a new place. But if they've in their own home, or if they've been there for years, this is not my home. I don't live here. Who are you? You don't belong here. And that's a pretty significant level of dementia. I just had a lady that was in clinic, and she thought there was a duplicate house that she was taken to, and you could only get through it through the closet. And she couldn't figure out why she couldn't find the door in the closet. It was really upsetting to her. The real house. She couldn't find her real house. So it can be all kinds of things like that. And then they can have visual hallucinations, auditory hallucinations. That's not very common, though, I would say, for Alzheimer's disease. Vascular dementia, usually people have had a stroke, but you always tell people that it may not be the major stroke you think of. It may be these teeny tiny little TIAs that add up. So maybe they couldn't speak for a few minutes and then it's over, but if you have enough of those, it can really damage your brain in lots of spots. And so that can lead to cognitive problems and then other issues, speech problems, psychotic symptoms, that kind of thing. And a stroke yields a ninefold increase in dementia risk. So if you've had one stroke, you're at high risk of cognitive impairment, even if you seem like you're doing okay initially. Memory impairment isn't always the first thing that happens, because it depends on where the stroke was. Where it hit may not hit your memory center. It might hit your language center. It might hit your deeper structures where it's more of an association pathway. And so it might show up more like, I suddenly can't pay my bills anymore and I was able to do it, but it's not memory related, something like that. Delusions are more common than in Alzheimer's disease. There's usually not a lot of psychotic hallucinations. And unlike Alzheimer's disease, it's not stage related. So if they had a stroke many years ago and they've had many more strokes, it's not necessarily like the burden of stroke that will suddenly lead them to become psychotic. It can happen after the very first one. So that's another clue if it's early on and they haven't had a memory impairment for long or no memory impairment. Dementia with Lewy bodies is becoming more of a diagnostic entity that people are familiar with. The core features are visual hallucinations, Parkinsonism, which is different than Parkinson's disease, but sometimes looks like it. And people can have fluctuating alertness or attention, like delirium. So sometimes what will happen is people will be in the hospital and people think they're delirious because they have this waxing and waning, but they can't find a reason for it. And this may be, in fact, what they're starting to have is Lewy body dementia. And then repeated falls, syncope, passing out, sensitivity to antipsychotic medicine, delusions, and other hallucinations can be supportive features. They also may not have memory impairment early, but they typically have it pretty soon after they have these other things. And that's different than Parkinson's disease, which has it later, usually. And the main thing to remember, I think, for people who look at medication lists or are hearing about people's story is that they're incredibly sensitive to antipsychotics. So if you suddenly meet somebody who's walking like a lead pipe or falling a lot at the nursing home or at home, and they're on Risperdal or Haldol and they've had this history of visual hallucinations and that's what they're using, they may have Lewy body because they are really, really sensitive to that. And so we like to pick two different agents if we need to use one, and that's because they tend to cause less of that problem. So quetiapine or Seroquel is the one that practically we use. Clozapine's very hard to use because you have to have a blood draw every week, and so most people don't use it. Sometimes people will have hallucinations, and they're usually pretty well circumscribed. So they'll say, oh, you know, there's a bunch of little kids in my room last night, and, well, what were they doing? Nothing, they're just standing there. Were they talking to you? No. Did they scare you? No, they're just there. So sometimes they'll just have that, and it's really not a problem because they're actually not distressed by it, but they're talking about it, and their family's like, what is going on with them? And give them something, you know, but they're not doing anything, and they're not particularly scared. You don't need to give an antipsychotic, and you should not, actually, because they can have a lot of side effects with them. And then they can have Capgras syndrome, and then phantom boarder, which is like, you know, there's some random person living with me off the street, and I don't know who they are. Oh, it's my son. I didn't realize that. And then this is just to point out the differences between Parkinson's disease and Lewy body, because they're hard to sort out sometimes. But usually Parkinson's disease will be identified by the movement problem. So they'll be falling, they'll have, you know, tremor on one side usually. They won't swing their arms, they'll have this flat affect. And then they'll get put on a medicine that helps their movements. And then Lewy body, sometimes we'll get those kind of medicines, and sometimes it helps, sometimes it doesn't. But they will have visual hallucinations early without medication. And their cognitive problems start a lot earlier. So if you hear visual hallucinations, early memory problems, and then sensitivity to medications or dopamine agents didn't help, like Cinnamate, that's probably what it is. And then frontotemporal dementia, I'm not going to spend much time on. Not a lot of memory impairment, not a lot of psychosis. Usually they get identified as bipolar, late onset bipolar, end up in the hospital because of their behaviors or personality change. They get fired from their job, they suddenly have an affair and take off. It's like really atypical for them. And that's a totally different entity, which I will not go much into. So this is going on with case 1. So this person finds things moved or missing. That's her evidence. She's never seen or heard anyone, but finds her door open. So she actually doesn't have any hallucinations at all. She hasn't heard anybody telling her something's being stolen. And she probably is leaving her door open because she forgets to shut it. But she thinks somebody's coming in. Somebody could be coming in. You still don't really know for sure, but the evidence seems not really there. No history of stroke, so you can pretty much rule out vascular dementia. She doesn't take any over-the-counter medicines. You saw her medicine list was pretty short. She's not using alcohol or drugs. Sometimes she doesn't take her medicines, but there's really nothing to withdraw from or complicate things from her list. And she has no prior history of this. So you can rule out pretty much any major psychiatric disorder from early life. And she doesn't really have much in the way of mood symptoms. Her mini-mental is 17. She was a college graduate, so that's bad for her. We did a geriatric depression scale, but it's that subthreshold for depression, but it shows signs of distress. So it wasn't that she had 0 symptoms, but it was subthreshold that we didn't really think she had depression. She said she's so upset she'd kill someone if she thought they were stealing from me, which you should definitely listen to. She hadn't identified anyone in particular, but the threat is there. That is next level concern of psychotic symptoms because they may harm somebody. And she's very upset and very frightened. And she thinks her family's involved because they haven't caught the person. So why aren't you, if you're not with me, you're against me kind of thing. And the family's concerned because the police are calling them, what's going on, and the building manager's calling them, you need to do something with your mom because she's, accusing people of things. So there's, a lot of concern from the community and from the family. So usually for psychosis and dementia, you want to think about a couple things. You don't have to give them antipsychotic medication. Sometimes you really have to. Or you get to that point because you try something else and it doesn't work. If the symptoms are mild and they just need some medication, this is part of dementia, they're distressed, it's mild, maybe they're spending too much time by themselves, they need to get out and be around people so that they have something to counter their reality. And you talk about the patient, how distressed they are and how concerned they are. You may not need to use any antipsychotics. If they are having a behavioral problem or the patient's really distressed, usually we do recommend medication. They don't have to take it. No one can force them to take it unless they're committed. And usually we're using very low doses, like 1/4 to 1/2 of what we use in like schizophrenia. So low doses. And then we try to still increase their activity, get them out of the house, try to engage them. Psychosis is really scary. If it's not the patient that's scared, it's definitely the people around them. Well, they might murder me. They're going to be unpredictable. What do I do? There's all kinds of stories in the news about people that are psychotic and what they do. So it's a really scary thing. And so you can understand where people might be scared or upset or worried, including the patient. It's also associated with agitation and aggression. So sometimes people think someone's going to harm them, so they'll hit somebody at a nursing home or their spouse. And that's a problem because you can get hurt. And also you can't deliver care that you might need to. And it's also a predictor of functional decline. If somebody's living at home or in a lower level setting of, then say, a memory disorder unit or something like that, that's sometimes one of the triggers for placement because it's really, really stressful and people burn out. And they don't know what to do about it. And the patient's quality of life is often impacted. And I think when I look at risk-benefit, how distressed is this person, and are they not doing anything that they might enjoy because they're so paranoid and so psychotic? And for me, that's the dividing line for risk, is that. If this person's really, really distressed, it might be worth the risk. So that the antipsychotics and dementia trials, there's a trial, the KDAD trial, which is specifically for antipsychotics and dementia, and they studied multiple agents, and they did show some efficacy in terms of agitation, particularly in psychotic symptoms, but they also had a high burden of side effects, so people tended to fall, they had extrapyramidal symptoms like tremor, rigidity, they were sleepy, they got diabetes, they had high blood pressure, and not in this study, but eventually people can develop a movement disorder called tardive dyskinesia if they stay on the antipsychotics. So they shouldn't be taken lightly, but they do also work in a lot of cases. The problem is you can't predict who will respond. And there is a black box warning from the FDA for increased mortality in dementia in particular. So it's not really a small problem. They're also expensive. So it's one of the biggest drivers of our healthcare costs in long-term care settings is antipsychotic medication. And so that should be on the list as well, because some people can't afford to take them. I listed the ones that showed the strongest evidence base in that particular trial and the dose ranges. And I don't mean that you start people on that low dose range. I mean you start lower than that and go up to potentially that dose. So start really low and go up as you need to. So for this case number 1, the treatment in this particular case, the patient and the family got education. We recommend the Alzheimer's Association because she had dementia and they needed some support around that and how do you cope with her accusations and how do you support her. She got started on risperidone or Risperdal, 0.25 teeny tiny dose at bedtime. We gave her clear informed consent and she and the family were both okay with trying it if it would help her distress. And we discussed also medicines for dementia treatment, but they weren't ready to do that, and we usually do one thing at a time anyway. And then we recommended some outings to getting out of the house more and socializing. She didn't have any response, so we went up on the dose a couple of times slowly, and eventually decreased delusions. She went out of the house more, and eventually she agreed to go to an assisted living facility because she was really distressed about living by herself. Really, a lot of it came down to that, and she needed more help. They decided ultimately not to treat her dementia with any other medications, and eventually we tapered the antipsychotic, and she did fine off of it. We did the transition to assisted living facility, stable there for a while, and then we transitioned her off of it, and it didn't recur. Sometimes it does, and then you have to put them back on it if the patient and the family agree. Okay. I'm trying to watch my time, but I don't see the clock up here, so I'm trying to keep track. So delusional disorder, I'll mention only as a differential because sometimes they don't fit the typical picture of dementia. So maybe you do their mini-mental and they have a normal mini-mental status exam, or they're functioning seemingly fine, but they come in and they have this particular, being stalked or a particular concern that they have. Sometimes things are being stolen too, so you have to sort of sort that out. That's why it's important to know sort of their cognitive level. They don't meet criteria for schizophrenia, which I'll talk a little bit about. They function pretty well. So if you sat next to them on the bus, if you didn't start up a conversation that triggered this issue for them, you wouldn't know because they act normally, they dress normally, they usually have worked, they've been married, they function well. But it is a differential. In later life, the second peak in disorders is more common in women. And late onset schizophrenia, that's true also. And people think it might be hormonal. Maybe, of course, everything in women is hormonal if it's more common in women. That's the automatic response. Who knows? They haven't really figured that out yet. They function higher. They usually have been employed. They almost always have hearing problems or they can't see. So that's, I don't know why that is, but it seems like they can't sort out the world very well in terms of what's going on. So for them, and this is true of most psychotic disorders, you really want to try to establish rapport. And what I mean by non-confrontational engagement is don't say, you know, that isn't true. It's not going to go well. Just, you know, wow, that sounds really hard. That sounds very, very distressing. Tell me a little bit about how that affects your life. What do you think about that? How distressing is that for you? And, you know, you have to sort of build a alliance with them so they might consider your treatment. Gather collateral history. Is this possibly true, or is it actually happening to them? You want to get help for the family and caretaker because often it's involving them too. Like I get called all the time by her that something's happened and I don't know what to do about it. Antipsychotics actually work well for this. Getting them to take it is a totally different story, and this is different than dementia. So while they still have, you know, risks of metabolic syndrome and tardive dyskinesia, they do not necessarily have the risk of mortality. That's not true of all psychiatric diagnoses with psychosis, that increased mortality exists. They are kind of people that you might want to think about a depot medication, meaning a shot, because they will often go off of their medicine. Even if they've had a good response, they'll think they're fine. And so if you can convince them to take that, and I usually sort of say, wouldn't it be nice not to have to think about your medicine, sort of like birth control? You know, you just get the Depo-Provera shot, easy. And if you have a good rapport with them, sometimes you can convince them that. But you really want to have a good oral trial because that's in their system for a long time. So you want to make sure they're not having side effects. I'm not going to spend a lot of time on this, just to say that people with schizophrenia that have had it all their life have cognitive problems anyway. It's part of the illness. It's not dementia. But they tend to function below most people's baseline already because of their illness. And it's not just their psychotic symptoms, it's really the way their brain works. It used to be called dementia precox, meaning early dementia, by the people who labeled schizophrenia. And so they already have some of the deficits, and often it's really hard to tell when they're having dementia, but usually it's some change from prior baseline. So the second case, what time is it? Just like, oh, there, okay. So I just want to make sure I don't I skip over appropriate things. So this is the second case. I purposely picked almost the same profile just to give you a sense of how they're different. So it's an 83-year-old widowed woman living alone, retired administrative assistant. So work history, also widowed, living alone. No prior psychiatric history. Same medical problems as the prior case with hypertension and osteoporosis. Calcium, atenolol, multivitamin, pretty standard. New onset of a delusion that she's under surveillance by the U.S. government. She has auditory hallucinations of multiple voices threatening her and talking to each other. So that already is sort of a totally different story. Usually that's pretty classic for schizophrenia. So multiple voices talking to each other. Not all schizophrenics will have that kind of voice, but if you hear that, it makes you think that particular diagnosis. No prior history of that, though, so most people think, is it possible she could have that or not? She's not sleeping well. That's a common problem in some of these psychotic disorders. They don't sleep well at night because they're fearful. She feels like she's getting zapped on her legs with rays by these voices that she can't see. So that's a tactile hallucination. The voices, these people that she can't see, can see into her purse and checkbook, she thinks. So she stopped paying her bills. She doesn't open her checkbook. She doesn't want them to know how much money she has. She thinks they read over her shoulder, so she stopped reading because she didn't want them to read what she's reading. The voices tell her to give them money, and then they'll go away. And she was pretty adamant she was not giving anybody any money. She was very upset. I am not giving them money. She did have a UTI when she first came, but they treated that, and it did not go away. So that would be pretty unusual for delirium to have that kind of presentation anyway, but at least they ruled that out. And she had a big workup, an EEG, she had CT scans, blood work, all kinds of stuff, and all negative. She did have hearing and vision impairment. She was distressed, anxious, tearful, so you wonder about psychotic depression. She didn't have any IADL or ADL deficits, meaning activities of daily living or independent activities of daily living. And we had collateral from her daughter, so that wasn't just her story. Her not using the checkbook was not because she didn't know how to use it. It was purposeful related to the delusions. So she was not doing that because she was psychotic. Her depression scale was 4 out of 15, and usually 5 or above is threshold, so it's still, you know, a question of whether she might be having depression, although typically psychotic symptoms happen after the onset of the mood. For psychotic depression, you'd have to have the mood symptoms and then have the other thing. And this is also pretty atypical for depression with psychotic features, to have two voices talking to each other. The mini-cog is a 3-atom recall with a clock draw, and that's a good screening evaluation for cognitive impairment. And hers was actually normal, which is 4 out of 5. She had a mini mental status exam that was 22 out of 30 when she was not taking any medication for this problem. And then she improved to 28 out of 30. So it's an example of once you treat something, sometimes what you think might be dementia goes away, or at least is less of an issue. She had a couple of trials of medications before I saw her. She had Seroquel up to 50, which is a pretty low dose, but she couldn't tolerate it because she felt zombie-like and no energy, wasn't getting better. And she also tried olanzapine or Zyprexa, and she got some muscle tightness, and usually people just stop it then because they don't want to cause falls and things like that. So she actually had late onset schizophrenia, which you won't probably see a lot, but it's just something I want you to think about because it does actually occur, and sometimes their outcomes are a lot better than some of the other psychotic disorders. And you don't want to tell somebody they have dementia when this is actually what they have and they don't have that problem, because it's bad enough to have schizophrenia, and then if you say they are demented too, that's another problem to have. So it's really not very common, but it does occur, and so just as a point of clarification, it's possible to develop that later in life. Okay. More common in women, I mentioned that. They're usually higher functioning. They often have sensory deficits, just like delusional disorder does. And they often have hallucinations in other modalities than just auditory hallucinations. And that may be in part, if they have sensory deficits, their brain may be trying to make sense of things that they can't see very well, and so the brain's kind of filling in, so they might have visual hallucinations for that reason, and trying to make sense of the world with these problems that they're having. They tend not to have a family history the way a lot of people do when they have schizophrenia at a younger age. So there's usually not a family history of someone with a chronic mental illness. They often will just need more support than they're getting. And this is a good rule of thumb for almost any problem that comes up psychiatrically. They often need help with some of the things that they've used to be able to do just fine. So they might need help with paying their bills or chore support or identifying someone to make decisions for them later. Medication monitoring, those kind of things. Those are things you talk about along the way. So that's even when their cognition is minimally impaired. For treatment of schizophrenia, you'll see a theme. Almost all the psychiatric disorders, we use the same kind of medicines. These people need higher doses, which is another reason it's important to figure out, because they might need higher doses to get better. So sometimes what will happen is people will give up and then they're not better because they've had multiple trials and nothing worked, but they didn't ever get above a high enough level, which is understandable, as people don't always know this exists. Okay, so she was started, I again used the same medication, risperidone, a little bit higher doses. She got up to a little bit higher doses than the prior lady, and did get better, but she had some side effects, so we had to lower the dose. And she's been stable. Unlike somebody with dementia, we tried to lower her dose, and she got more psychotic again. So we had to find a good dose, and she has to stay on that medicine because she has recurring symptoms. So her illness is a little different than someone with dementia with psychotic features. And she's now living with her daughter, and her cognition is a bit worse than it was. And one question people often has is maybe late onset schizophrenia a sign that they may be developing some kind of cognitive disorder that hasn't shown up yet. And I think that's a strong possibility, but legalistically they don't meet criteria for the cognitive disorder, so you can't diagnose them with dementia. Some of them develop cognitive disorders and some don't. So it's probably a mixed picture. Okay. So the treatment choice for medicines or non-medicines is usually you just want to pick the closest diagnosis, best possible diagnosis. Try non-pharmacological things if you can, and or in addition to medication. You want to know what you're treating, so you're not just randomly throwing medicine at something, behavior. What is it that you want to get better so that you can see if it does, so you know if you can stop the medicine or if you need to go up on the dose. The comorbid medical conditions goes into what choice of medicine you might pick, because some risks with certain medical conditions than others. There are potential drug interactions with other medications. You have to look at that. Another big way of picking a medicine is cost and what's on formulary. You will not know that, but they may call you and say, I can't take this because it's not covered. So all things being equal, start with the cheapest one if you don't have a reason not to pick it. And then if you think they might need an injectable medicine, you might want to start that kind of medicine first, because not all of them come in that. Or if they might need a liquid or a salt tab or something like that, because some medicines come in that, some don't. So say somebody has swallowing problems, or they have a PEG tube, or they have something else, you might want to think about that. Prior trials, this is kind of reiterating things. Decide if you're going to treat them short-term or long-term. Monitor for movement symptoms so that you know if you need to lower the dose or be watching for falls. This is just a list of some of the medicines that we use and the types of dose range. That's more for reference. So you want to assess the treatment course as you go. People who work with patients that aren't treating them necessarily as a medical person can still have an input. Hey, this person seems really stiff. They're on Risperdal and they've been on it for like 6 months. Do you guys think maybe we should try less? Or, if they seem really to be having some trouble with that. I think it's good for everybody to have input into that, or if the family is concerned or the patient's concerned. And then long-term or short-term treatment, try to get them on the lowest effective dose or off of it if you can, and keep monitoring for side effects. You got to talk to the people around them. What are their fears? What's the patient's fears? What do the patients want? What do the family want? If they don't want antipsychotics, don't use them. Try something else, but say, I don't know if this is going to work, but we'll give it a shot. I'm always willing to work with people on that, because some people don't want the risk, and that's perfectly acceptable. Educate them about the disease that you think they have and what they can do. Give them reassurance if you can. Talk to them about their own problems, because often these caregivers are really stressed and depressed and burnt out, and talking about if this doesn't get better, what's your plan, so that it's not crisis-driven necessarily. They're starting to think ahead, and what support can they have, and also for the patient. These are some good resources for dementia care. The Alzheimer's Association I mentioned because it's not just Alzheimer's disease. It has all kinds of information on there. I think you maybe have some information from earlier, but all kinds of languages, 24-hour care line. It's a really, really great organization. Lay language and information for medical providers, on support groups, on research studies, all kinds of stuff. And they talk about different kinds of dementia and the different medicines and behaviors. Caregiver Alliance, just for resources for caregiving. The 36-Hour Day is a really old book on caregiving and dementia, and it's really good. It's still classic. If you live in King County, which most of you don't, we have a geriatric regional assessment team that can go out if people won't come in or can't, that can assess for this kind of symptoms and offer care. And then NAMI and NIMH are just good resources for chronic mental illness or mental illness in general. Okay, and that's just stuff that's on the Alzheimer's website. These are a couple recent reviews for people who might want to read more about the medical side. They're good updates on use of antipsychotics in older adults. This is just kind of a summary. I'm not going to go through it again. You might want to refer to someone like me if it's complicated and you can't figure out what the diagnosis is or what you're trying isn't working. So really the summary points are that this is a really common problem in older adults. It's often a manifestation of dementia, but it's not the only cause. And schizophrenia is by far and away not the most common cause of this. So despite my consults in the hospital for acute onset schizophrenia in a 90-year-old, not common. But that's what people think of when they have hallucinations and delusions. You want to identify targets. And I emphasize that because people just often throw medicines at something, but they're like, you can't tell you if it's getting better or not because they don't know what they were treating in the first place. And that's a bad use of medicine because it's a high-risk medicine for unclear reasons that you're using it, and that's not what we want to do. You always want to be aware of what comorbidities they have, and side effects are common. So start low, go slow. If they have a side effect, back down if you can, and try to get them off if you can. Always, always, always informed consent. And in terms of the risks of death and dementia in particular, I can tell you in honest discussions with families that have a demented patient that has a problem that really is causing a lot of distress and a lot of behavioral issues, that when I discuss this, they say, I don't want my parent to feel this way. I don't want them to get kicked out of their housing. It's worth the risk to me. These are people that often the patient can't really comment. They're too demented or they're too distressed, and so usually the family is having to make a decision. Almost always they will agree to taking a medicine, even when they're offered other choices. So that's the level of concern that people often have with these kind of symptoms. But respect them if they don't want to do that. That's okay. I think that's it. That's it.
Okay.
Yeah. So I'd be happy to take questions.
Do you have any questions? Oh, you've got one from Anchorage already.
Please define differential. Okay. So what I mean by differential, I mean what are all the potential reasons people might have a psychotic symptom? So what are the things that you're trying to sort out between? So is it a medical problem? Is it dementia? Is it a side effect of a medicine? So the differential is which category is it in and which is the most appropriate diagnosis. So that's what I mean. And the ones that I listed are the most common possibilities in older adults.
Questions from the group here? I actually have a question.
Yeah.
When you were talking about your case study and some typical things that might happen with psychosis, some of those seem to be things that you could, for example, the thing about the rays on the legs could be somebody who's got restless legs problems. So to what extent might they be not so much hallucinating, but instead misinterpreting, filtering their experience through some odd thoughts?
But I think in that particular case, it was in addition to the other things. There were so many other things that were glaringly psychotic. But yeah, I think if she didn't also have common things that go with, like no diabetes, nothing that would indicate that she had peripheral neuropathy, for example. That might be that creepy crawly or the zapping feeling. But it's certainly something you want to try to rule out. It's really hard to do that sometimes because it's hard to, do a blood draw or something like that. But sometimes if that's, say, the only symptom and there might be another etiology, it would probably be better to treat for that if they can tolerate the distress from it and see if that part gets better. But she had it all incorporated into this particular case. But I think it's important to rule out medical things for sure, because you definitely don't want to be throwing a medicine that's not for that, that's high risk. So, how is someone diagnosed with schizophrenia? It's a clinical diagnosis, so similar to dementia, which is also a clinical diagnosis generally. People have usually a core cluster of symptoms, and classic are hallucinations, delusions. They often have behavioral disorganization, meaning they're doing unusual behaviors or patterns of behavior, or they don't function at all. And they have had medical etiologies ruled out, and it's sort of a diagnosis of exclusion. You have to rule out medical problems, you have to rule out mood problems, you have to rule out side effects of medicine. Just like anything else in the psychiatric disorder, you want to rule out everything that's not a psychiatric symptom. So, is there a test that can be done like a mini mental for Alzheimer's? So the mini mental status exam is a kind of a standardized bedside assessment. It was originally designed to detect dementia of the Alzheimer's type, and that's still probably the best use for it. It's one piece of information, really. You can't just say they have this score and they have dementia. It's a part of a clinical history. So they have to have the other symptoms that I listed, like they have memory impairment, or they have to have some loss of other function, word finding problems, or they can't remember how to do things. So it's part of an overall assessment. So there's no actual test that can be done for it. It's more of a clinical diagnosis. There are more things you can rule out. Like sometimes we will do like a head scan to make sure there's nothing else that might be causing that problem in their head in lab tests.
I think I'm wondering if they were also wondering if there's a test for schizophrenia similar to how MMSE is.
Oh, okay. I didn't interpret it that way. Okay. In terms of the diagnosis of schizophrenia, no. It's a clinical diagnosis. So I guess the best thing I could tell you is to get a hold of a copy. You can even just put it on Google and put, Diagnostic Statistical Manual Diagnosis of Schizophrenia, and it'll list the criteria of that. What is the morbidity rate when you give antipsychotics? Yeah.
So I'm wondering what your thoughts are. A lot of this is focused on using antipsychotics for psychosis. But what about other behavioral disturbances, like aggressive behavior, for example, hitting, spitting, that kind of
Agitation, I had that question.
Yeah. So I didn't focus on that because you had a so the question is, what about non-psychotic or potentially non-psychotic behavioral issues like spitting and hitting and the use of antipsychotics? And I purposely didn't focus on that because I know not everybody went to every lecture, so but there was a lecture that was focusing on behavioral syndromes in dementia and some of that, and separate dementia lectures on diagnosis. So I actually left that out on purpose. The evidence for most of those behaviors is not great for antipsychotic medications, but sometimes when they are interfering with care, we do use them, and these are always off-label unless they actually have a psychotic symptom. So they're high-risk medicines that you want to make sure that you're thinking about. Spitting is a hard one. Aggression, you want to try to get at as much as you can around what else might be going on. Pain, approach, so watching people try to give care, because sometimes you feel, I don't have any problems with that person and this other person does. And that can be the time of day, it can be how they approach someone, it can be anxiety, it can be that they hurt, maybe are too rough in their approach. And so sometimes just watching the care can help with that. And I don't mean to blame caregivers at all, because it's a really difficult job. But sometimes we don't do enough of that to try to get at what the problems are. What was the other one? Spitting?
And you said agitation.
Yeah.
I was just, hitting, spitting, those kind of aggressive
Yeah.
things. But then agitation.
Yeah, do you equate psychosis and agitation?
Well, it's hard because, so what the question was from the audience was, do I equate psychosis with agitation? And no. Agitation can be from psychosis. The problem with dementia is you often can't they don't have enough language to tell you what's going on by the stage that they're in, for example, a nursing home. It's not to give any disrespect at all with people with dementia, I don't mean it this way, but it's a lot like pediatric medicine or veterinary medicine, in the sense of trying to figure out what's going on. It's often observation, it's trial and error, it's thinking about common things and trying to do things that you think might help, depending on the urgency. So sometimes people are, say somebody thinks they're medically ill and they can't get anything done to evaluate that. They won't let them draw blood, they're hitting people, they're scratching, they're biting. We may use an antipsychotic in that level of agitation because it's dangerous to the caregivers and it may not allow us to get information about a treatable cause. So for example, that would be one example. Same thing in a hospital. For delirium, sometimes people have that level of agitation and psychosis. So you try not to if we can, but they are used very commonly, I can tell you, in nursing homes, but people are trying to get away from that because it's basically a chemical restraint, and people don't want to do that. But there's a level of danger and distress that people have that often requires that. So it's a good question. Because that's often the most common reason people are used for agitation. And that's why I say be as specific as possible, because then you're trying to know, what is it that they're doing that you're concerned about? Are they disrobing? Are they touching someone? Are they hitting? Are they spitting? Are they calling out? Are they, exit seeking? Are they smearing poop on the wall? Are they swearing? There's all kinds of stuff,
So Missoula was wondering, what is the morbidity rate when you give antipsychotic medicines to dementia patients?
So the rate, boy. So morbidity means adverse side effects, and that's difficult to put a number on because there's a lot of morbidity that can happen. So there's blood glucose problems, there's potential movement problems, the what else? Weight gain. Those are all morbidity. That means bad outcomes, side effects. Death is a different story. It's actually less than it's like a 1.5% increase. It's a pretty low increase, but it's higher than the average rate of death. And it's an association. It's not necessarily that they can link it. It's just an association with being on the medication. People die from pneumonia. People die from cardiac problems. And it's the association that they have is that they have strokes. Those are some other things. And there's a higher than average risk, but it's an association. It's not been proven to be causal. It's just that it's hard to not identify that as a risk. And so, for example, for pneumonia, is it because they're too sleepy on the medicine and they aspirate and they get pneumonia? It's possible, yeah. Would they have gotten pneumonia anyway? Maybe, but we don't really know. It's just an association. But it's important enough to the FDA, particularly with, I think, the overuse of those kinds of medications in dementia, that they, I think, really, really want to force people to think about that, and I think it's a good thing. So I think I missed a couple other...
No, I think you're okay. Why
Okay.
are most people with schizophrenia concerned about people taking or stealing their money?
Most people with schizophrenia actually aren't worried about that. People with schizophrenia, in the classic sense, are usually more worried about how the world is treating them. So maybe harm is going to befall them, or the world's a dangerous place. There are certain kinds of schizophrenia where that's the case, but it's actually not probably the most common. That's really common with dementia, stealing money, and sometimes it's true. I work at a nursing home with somebody here in the audience, and I've been involved in probably 5 cases where that was proven to be true, where the family was actually financially exploiting the person, and so they had a guardian and a restraining order, and it was true. So it's hard because you don't it's hard to investigate, but Adult Protective Services gets involved in that, and that's probably the best route to go about trying to figure that out, because they can do an investigation and try to figure that out. So in terms of dementia, I think there's a lot of fears in older people in general that they're not going to have enough money to survive on, and so I think the truth about most psychotic symptoms is that it has a kernel of truth about what they're worried about sometimes, or they've had some experience with that before. It's not always the case, and they can't always explain that, but often there's an element of truth to it, but it's gone beyond the usual concern level. So I guess that's how I explain it.
Other questions from the group here?
Looks like Missoula is typing, so let's see.
Okay.
There you go. If they have dementia with aggressive behavior, not sure if it's a UTI, refused analysis, suggest emergency room, caregiver worried for safety of grandchildren in the house, should she be referred to a psychiatrist, trying to figure out the best place for the patient to be diagnosed.
Oh.
Sort of vague symptoms.
So, I think this sort of falls into the category of aggressive behavior, say that we were talking about. If you can't figure out what's wrong, like you're not sure what their behavior's from, and you can't get the evaluation done, that would probably be a situation where either a primary care doctor, I don't know that a psychiatrist would necessarily need to be involved. Some places just don't have access to that, and from Iowa, I know rural stuff is difficult. It's hard. But I think if people can't get the medical evaluation done, I think it's probably worth a trial of a medication just to see if you can start to talk about what's actually going on, and then maybe get a further evaluation of their medical system. In our county, that would be, if there was some kind of concern about the safety or well-being of somebody, and they had, like, say, directly threatened someone, that would be grounds for evaluation for involuntary commitment if they wouldn't agree to go in. So it depends on how eminently you think they're in danger. Because I would never say just start an antipsychotic if you're worried about somebody in the house that you think might be in imminent danger or has been hit or has been threatened directly. You definitely want to get somebody involved. And you can take them into an emergency room if that's the case. In our county, I don't know how it works in a lot of other places, but they will come out to your house and evaluate that if you call it in. But that's not available everywhere. So sometimes it is the emergency room that gets tasked with that, or primary care doctors. So. But never ever underestimate the possibility of people having, assaultive behavior or self-harm, because that's why we think about the stress so much, because they may be so scared that they are unrealistic about who's doing it. And so if they've ever directly threatened anyone, or you're the recipient of a threat, or somebody in your house is, I would say that that's an emergency. That's a psychiatric emergency, I would say. So there might be more to that story, I'm guessing, but that's the best answer I can give right now. It's a good question. Yeah.
So it's been quite a while, but I was making rounds with someone who was using antipsychotics it seemingly to calm people down and stuff like that. So now, like the benzodiazepines, are they preferable? They're used also, aren't they?
Yeah. So the question from the audience is noticing the use of antipsychotics to calm people down, like in a nursing home, or nursing home, and what is something like a benzodiazepine, like Ativan, or in that class, is that preferable? Yes and no. So I guess the sort of wishy-washy answer is almost all psychotropics have risks in terms of sedation, falls, confusion. So there's not necessarily one better than another. I would say that the mortality, there's a better mortality risk, but you could argue that falling and having a hip fracture because somebody gets confused or over-sedated on a benzo, they could die from that too. So it's sort of iffy. They are probably being used a little bit more often because of this FDA black warning, and for some things it does work. So usually benzodiazepines I reserve usually for when there's a sleep issue. It's not necessarily psychosis. If it's a particular thing that they have to get done, like they're always scared about a blood draw, or they're always combative with a shower, but it's only once a week, then I might use it for that one time rather than an ongoing basis. But usually, the benzodiazepines don't have a very good record in research studies for improving things other than due to sedation, which may in fact be, in some cases, what antipsychotics do too. So the answer I usually give is I don't usually like to put people on that all the time just because of the risks for that. But for very anxious behavior, like calling out behavior, things like that, sometimes we use it for that, or for very specific cares that need to get done, and hopefully just short term. And the other route for that is SSRIs or antidepressants, but they take a while to work is the problem. And sometimes they don't work very well either. So calming, if it seems like it's an anxiety problem or it's something like that, sometimes that kind of medication class is better because they, that might treat a lot broader group of symptoms. That's a good question. I had somebody call me one time from Group Health, actually. It was a psychiatrist I used to work with, and she said she was checking the standard of care about use of antipsychotics because everyone was using benzodiazepines. So it's an issue, it's an issue of decision. I still don't use them. I use a lot more less antipsychotics than I used to, but I still use them quite a bit because they work. So. Yeah.
So someone who's having an older adult that has dementia and is having the psychotic symptoms, and you start them on an antipsychotic drug, how long do you have to wait before you know if it works?
Mm-hmm. So the question is, an older adult with dementia that's having psychotic symptoms, how long do you use it before you know if it's working? Is that sort of right? Yeah. So I would usually I will try at least one dose increase before I give up on a medicine. So if it seems like it's not working, say in a nursing home, I would try to see them within a week, hopefully, to see if it's working or not. Usually, once you get to, a second increase, if there's a little bit of room to go up, then you will do that. If it's not making any difference, I would say within a 2-week period at all, if you have the time. That's about the range, because they're quick acting. They're not like antidepressants that take weeks and weeks to work. They work right away if they're going to, including for psychotic symptoms. So, yeah. And you can get them off of them once they're stable after a few months, or at least try. In nursing homes, we're required to do that every quarter or so once they're admitted, to force an evaluation of that. So. But sometimes people just end up getting stuck on them and left on them, and that's not a great thing. So. Somebody else is typing. Oh, thank you.
Thank you.
Okay.
All right.
What is a black box warning?
Oh.
So the FDA has, which is the Federal Drug Administration, has high alert warnings about medications that come out from time to time. And they're from anywhere from any kind of drug, basically. And often they're the drivers of when drugs get taken off the market. So sometimes they'll be, suddenly X amount of people had liver failure. X amount of people had cardiac arrest from, when they were taking this medication. And so it's a way of saying, really, really think about using this medication because people are dying from it, or we think they're dying from it. So it's basically something that gets put out by the FDA as a message to prescribers to say, this is the evidence, this is the research behind it. We really want to caution you in using this medication. Consider alternatives if you can. So it's basically, it's not an edict, you don't have to follow it. It's just, I would say, it's more of a way of forcing people to look at dangerous side effects. And from a practical standpoint, and I hate to do a medical legal thing, but that's basically for us what it comes down to is, can you explain why you would pick such a dangerous medicine for a patient? Do you have a good rationale for that? Because you can easily, if some bad outcome happens, you have to be able to explain it very well, in terms of a suit. And hopefully that should not drive our medical practice at all. But unfortunately it does. And so that's another piece of why we pay attention to that.
And it's often front and center on the patient package insert.
Yeah, right. And it probably should be, so that people are asking their doctor, why would you put me on this, So they're not, they're not evil medicines. I'll give you another example. Antidepressants have a black box warning for increased suicide risk. And the rate of teenage depression has gone up remarkably when people don't get treated with antidepressants. And the argument with that is they might commit suicide more often because their depression isn't getting better because they don't work very fast. So it's an association. And now it's for everybody. It used to be just for teenagers. Now it's for everyone. But we still have to use antidepressants because, we don't have any other options other than when people are very seriously depressed. So it's a mixed bag sometimes, medications. I have two more people typing. So I know we don't have a lot of time.
The ending thank yous.
Yeah, it could be. This looks like a longer than a thank you. And you guys, oh yeah, you can see questions.
Well, I guess it's potentially a detailed question.
Yeah. It's okay. Should have a call-in show. Maybe that would be easier. If you're like a type like me, it takes a while.
There you
So the question, you can read it, but the connection between stroke and later onset of psychotic behaviors or late onset schizophrenia. No, although I'll put it this way, that there's no increased risk in stroke with those diagnoses. Whether it's associated or not, I think is up for debate, because I think anything that goes wrong in the brain could trigger anything that looks like a psychiatric disorder based on where it is. So no, there's no linkage necessarily, or it's not considered to be a risk factor for those diagnoses. But there's enough delusions and psychotic symptoms that happen with some people with vascular dementia that I do wonder sometimes about the vascular connection. So the best thing you can do for that is prevent stroke in the first place. So treat depression, hypertension, make sure people actually get their blood pressure checked, take their medications properly, don't smoke. But yeah, I don't know of any direct connection that's been identified. Hopefully when I'm 80, we'll know a lot more about lots of these things. I hope. That's my hope.
Are there any thoughts about why late onset schizophrenia happens?
No, I think people feel the sensory deficit plays a role in people trying to make sense of the world. I can't see or hear, and something's happening, and I'm unsettled by it, but I don't know what it is. And I think your brain sort of tries to fill in gaps.
Can you repeat the question?
Yeah. So the question was why late onset schizophrenia might happen, or what's the reason for it. And people don't really know. It's been around for a while. It's been identified, as long as the rest of schizophrenia. It's just that it seems unusual because it's outside of the norm of what we expect for schizophrenia. So most of us who work in that area think it's probably something coming with the brain, or it's some kind of insult that's happened from something we can't identify and you can't see on an image. But they get better just like early onset schizophrenia, if that's what they have. So they're very treatable.
With medication?
Yeah, with antipsychotics. It's really actually one of the major reasons to identify that and sort it out, because unlike dementia with psychosis that sometimes gets better to the point where it's not as distressing, people with schizophrenia often get better and stay better as long as they stay on the medicine. So it has some elements of similarity, but I don't think we know why. And why would it occur more often in women? I don't know. That's just the association. So, but I've had probably 5 cases, and I didn't used to think it was real either, but I've seen, I'm a specialty person, so I'm going to see it more than anybody else, but I believe it's true, and I have no other explanation for it, so it's kind of the best we can do for now with what we know about medical science. So that's true of most medical problems. We do the best we can until we know better, hopefully not causing harm along the way.
Okay, thanks.